Our next speaker is Dr. Vinita Ramnani. Madam is a well-known person in the national circuit. She currently works as the HOD of the eye department at Bansal Hospital at Bhopal. And Madam is Central Zone Executive Member of the GSI, and she was the organizing secretary of the annual conference of GSI at Bhopal. And Madam is currently the Vice President of MP Ophthalmic Society. She's a recipient of several awards, the Ecoin Oration Award, the BOA Gold Medal Award, Sadhguru Medal, and a lot of other awards. And she's also held various positions such as Chairman Scientific Committee of the KSOS, and she's been the Secretary of the Secretary and Vice President of the Bhopal Ophthalmic Society. She has a very large work experience of more than 30 years, and she's performed more than 30,000 eye surgeries. A warm welcome to you, Madam. And Madam will be speaking on the topic management of coexisting glaucoma and cataract.
Thank you for such a wonderful intro. And I should be thankful to the whole society, Dr. Bastin, Rakhi, you, and many others sitting over here. And it's my first visit to this place, but then I'm really amazed the kind of a scientific content and the hospitality you have been given us. Thank you so much. So let's talk about how to manage coexisting cataract and glaucoma. So we know that the cataract and glaucoma, they can coexist because most of them are elderly and they can have the diseases together, and they can they can affect the diagnosis as well as the management of each other. And it becomes sometimes challenging because there is no definite guidelines led by the society, but then definitely you have to treat such patients either by continuing with the drops and doing only the phaco, or you may require two separate procedures, or you may require a combined surgery. So let's see how we should proceed, but definitely it is individualized. You have to see the amount of the cataract, you have to see the severity of the glaucoma and the individual need of the patient, and so also the experience of the surgeon. Sometimes we just wish to perform only cataract surgery to get rid of glaucoma, especially if it is early angle closure glaucoma, ocular hypertension in an early stage, or where IOP may be controlled with the single drug. So we know there is a drop of 2 to 4 millimeters IOP, and then probably the glaucoma may not progress and you may not require any drug. But then definitely there are many patients, especially in India, they are coming late to the diagnosis, and we are being forced to do either combined or two separate surgeries. Now that becomes a real challenge. That depends actually what is the reason why you are performing the surgery. It is the glaucoma or the cataract, what is the situation of the current glaucoma control, and what is the patient desire. So two separate surgeries, definitely you can do the trap first followed by cataract, or vice versa. But when you do it two separate procedures, definitely you have to give a gap of 3 to 6 months, and there are challenges in both the scenarios, whether you do the cataract first or you do the glaucoma first. But definitely if you do the cataract first, probably you will be managing glaucoma like any other glaucoma. But then only thing is you have to be careful about the IOP spikes. But then if you do the sequential surgeries, definitely it is the one that patient has to be taken to the theater twice, but then you are dealing two separate situations differently, and then you are addressing one at a time. So it gives you an advantage. So but in India, probably in our part of country, definitely the people don't want to go to the theater twice with so much of a issues related to finances, the travel, and so many other things. Probably combined could be one of the option, but trap, given a choice, if there is no visual immediate requirement, the TREP should be done first, especially in the advanced glaucoma cases. But make sure that tell the patient that you are not going to gain any vision out of it. It is just to control your intraocular pressure, and you might have a progression of the cataract which we need to remove later on. But definitely when you do a cataract surgery, then you have a lot of challenges, and because of the cataract progression, probably you have to do the surgery even earlier than 3 to 6 months. So you have to be prepared for it. And we can see that so many blabs are there, the non-dilating pupil are there, even the biometry is difficult. So there is a risk to the blab when you do cataract surgery following a trabeculectomy, and you may see lot of conditions where you have a weak zonules, you have a raised intraocular pressure. So definitely you have to be careful about managing the complications, and it's a bit of a challenge operating a cataract, which we routinely do. But then if it is because of the post trabeculectomies eyes, you have to have something in mind that this blab should not fail. There is definite 30 to 40% risk of a blab failure because of the inflammation, because of the scarring, because of the blab touch. So probably I am in a favor of doing a combined surgery, and it gives me an option that yes, you can combine it with the trabeculectomy, with valves, with non-penetrating procedures, with MIGS, and even cyclophotocoagulation. So you have lot many choices, but then over the years it has been seen that there's a lot of shift to the phaco MIGS. So most of the time it is not only the cataracts we are doing MIGS together to get the burden of the medicines over, or maybe sometime you can very well control, especially the mild to moderate, not very fast progressing glaucomas with MIGS phaco very well. So it's individual choice. If you are being trained into MIGS, you are into MIGS, and your patient is affording, you can go for various stents. But then definitely the many other procedures which doesn't cost you much could be a part and parcel of your cataract and combined procedure to deal with the glaucoma. Definitely the patient prefers this because there is a risk, there is a one visit to the operation theatre, and even the finances are less with this. They recover faster in comparison to the two procedures together, and there is no risk of an IOP spikes which will happen with the cataract surgery alone. So less trauma, more comfortable, better cost effective relationship makes this procedure a choice by the patient. But you should also saying the disadvantages, that you will require a longer recovery time, you require a longer operating time, and there could be unpredictable results because the phaco is a wound which is self-sealing and it's airtight, and blab of a trabeculectomy, if you are doing a combined phaco-trab, it's a leaky bleb. So you have to be very careful that you have a window which does not give you a shallow anterior chamber and hypotony in the immediate post-operative period. So it is a bit challenging when you perform two surgeries together. Let's see whether you do a combined phacotrabeculectomy through the single site or the two site. Single site is little bit challenging. We started with single site, but eventually every one of us now has shifted to the two separate site, doing a corneal clear phaco like any other phaco and trabeculectomy at 12 o'clock like any other trabeculectomy. So both has their own advantages and disadvantages. If you do a single site phacotrabeculectomy, probably you are saving the time. You don't have to position yourself. You can sit at one place, and in a single go you can do both the surgeries together. But definitely there is a lot of inflammation because you are going through the same port. There will be more handling, and there's always a risk of mitomycin going through that port when you do a cataract surgery first, and then you are applying the mitomycin. So you have to be very, very careful that mitomycin has to be used before entering into the anterior chamber. So I will show my video that how I started my phacotrabeculectomy, and I did it for years, and I was really enjoying this because there was nothing extra I was doing, but then I was offering a good control, especially for my charitable patients where I worked for 13 years. So you go for a single site phacotrabeculectomy, make a scleral flap, continue your phaco procedure through the same tunnel, and then you finish off your phaco the way you are doing, and then you inject the lens, and after injecting the lens you can cut open the inner window and do an PI. So that becomes much easier, faster. But nowadays, because we are not doing a scleral phacos, we are more into the topical clear corneal. So this becomes sometime a challenge. But then it used to be a very common procedure in our trust hospital, where we used to have lot of glaucomas coming from the periphery, and it used to work very well. It used to control intraocular pressure. Only thing is it requires little more recovery time. So you don't expect the recovery to happen in 2 weeks, 3 weeks time, but it may take 6 weeks to recover and stabilize the refraction. But definitely a very fast procedure and good control of intraocular pressure. But then nowadays I told you that my preferred approach is do the clear corneal phaco and do the trabeculectomy separately, so that you can do the justice to both the procedures the way you want to control the intraocular pressure, especially with the deep-seated eyeballs. When you have that very narrow working space, definitely this procedure works very well. So to summarize, we have the whole picture, starting from the ocular hypertension to a very advanced glaucomas and various types of secondary glaucomas. So they come across with the cataract together. What will you do? The protocol is like when you have an ocular hypertension, or you have very mild glaucoma, which is either angle closer or angle open, probably the cataract extraction alone can be an choice, but keep a strict watch on the disc field and the IOP to see what is happening to the glaucoma over the time. But if it is moderate, definitely you have to do something to control the intraocular pressure. You can do a combined procedure, which is really loved by the patients. You can do MIGS, so mild moderate glaucomas, cataract with MIGS is one which we are looking into, making the patient drug free and making the patient happy that glaucoma doesn't progress, and it's well accepted. But in advanced glaucoma with a very mature type of a cataract, a near mature cataract, becomes the challenge, because now you have too many things to tackle. So you can do a combined phacotrabeculectomy, and two separate site phacotrabeculectomy is really one which we have been doing for years and years, because MIGS, probably in advanced glaucoma you have to give additional drugs. So I think trabeculectomy, if you can nurture your blab, and if you are not worried about these post-op complications, you have to go for the two separate site combined phacotrabeculectomy. And if it is less cataract, doing two separate procedures depending upon the severity. If it is very advanced glaucoma, I will prefer doing trabeculectomy first and then cataract later on. And in secondary glaucomas, it is always good to have two separate procedures, because a lot of inflammation and many other things, that scarring and the bleb related issues in secondary glaucomas, it is preferred to have two separate surgeries rather than combining together. But in overall, it depends upon the patient's choice. Like if the patient is ill, especially in multi-speciality, very old patients with multiple cardiac or another issues, probably there is a chance for doing the combined and looking into the blab that it should survive. So there is controversy, but then it's good to individualize each case. Thank you so much for the patients listening and having me here. Thank you. And I will request just to vote for me for member scientific committee. I'm from Bhopal, Madhya Pradesh.
In case of SACs is trabeculectomy, due to some indications we have to do SACs and trabeculectomy. Will you prefer a single site?
I think it is always good to have two separate sites, because SICS wound is little bigger, so you wanted to have that tight closer which you were offering by doing a phaco, because the tunnel is smaller. But then if it is SICS, the tunnel is little longer and bigger, so probably there's a more risk of leak. But then in Trust Hospital, I did a lot of SICU strap and it's really worked well. But then now, over the years, we have learned that the minimal or smaller is good for our eyes.
For sharing your vast experience and making things clear for us.